A 28-year-old man presented with weekly episodes of spacing out, rising epigastric sensation, and deja vu. So he told me that he has had these for years but was never diagnosed with epilepsy. If when I started asking about his past medical history, he had a history of febrile seizures. So when he was 2 years of age with very high fever, he has had several seizures. I was not able to get details about those seizures from this patient. Overall, he told me that he had three tonic clonic seizures in his lifetime. So his episodes of spacing out and blanking out and deja vu were not diagnosed as seizures, at least until a few years before presenting to my clinic. And at that time, he was started on anti epileptic medications. He was tried on several different anti epileptic medications in good doses, but his seizures continued to occur. So these episodes were occurring very frequently. The three tonic clonic seizures were in the setting of missing medications. So when he came to my clinic based on stereotypical episodes of spacing out and blanking out, I was concerned about mesial temporal lobe epilepsy, and I ordered an MRI of the brain and admitted him for video EEG monitoring. So in this tutorial, I will review EEGs and imaging from this patient and another patient with mesial temporal lobe epilepsy. I will share some useful clinical pearls at the end of the tutorial. I invite you to read about mesial temporal lobe epilepsy. Typically, patients present with spacing out episodes and blanking out episodes. Tonic clonic seizures are very rare, are not very frequent with the mesial temporal lobe epilepsy. You can see more tonic clonic seizures with new cortical epilepsy or lateral temporal lobe epilepsy. So when we had an MRI done, this is what we saw on the MRI. What you see here, this is a coronal flare image through the hippocampus, and you are able to see an abnormality in the left hippocampus. So the three defining features for mesial temporal lobe sclerosis is number one, an increase in signal, number two, an atrophy, and number three is loss of architecture. So we see all those findings features here. So this MRI is very suggestive of mesial temporal lobe sclerosis or MTS. So he came in for an EEG, and the EEG demonstrated this is what we saw on the EEG. For those of you who are getting used to EEG montages, this is an average reference montage. We are comparing these channels are all recording from the left side of the brain. So channels that end with the odd number are recording from the left side, and channels that end with the even number are recording from the right side, and channels that end with the letter Z are recording from the midline. What we see here is slowing in the left temporal and subtemporal head region, and the slowing is rhythmic, and this is in the delta frequency. This is something that we call temporal intermittent rhythmic delta activity, or TERDA. When you see a TERDA on EEG, keep in mind that there is a very high association. Approximately 20 to 30% of patients who have TERDA tend to have temporal lobe epilepsy. So you can read up on TERDA a bit more. TERDA, TIRDA, temporal intermittent rhythmic delta activity. The interictal EEG also demonstrated sharp waves in the same distribution as the rhythmic delta activity. I recorded several seizures. This is one of the seizure. If you focus on the left side, you may be able to appreciate the onset of the seizure from the left hemisphere. This is the second page where the seizure evolves, and this is the termination of the seizure. So this based on the fact that this patient was having very frequent seizures of loss of consciousness, loss of awareness, some associated with physical injury, and the patient was refractory to medical therapy, had tried 5 different anti-epileptic medications with no significant improvement. We basically worked him up for epilepsy surgery. So the workup for epilepsy surgery you can start with a routine EEG. You can admit the patient for video EEG monitoring and try to capture at least 5 or more seizures to make certain that all seizures are coming from the same spot as where you see the abnormality on the MRI, based on the fact that this person had left mesial temporal sclerosis and the EEGs were basically correlating with the imaging abnormality. I sent him for surgery. He had a selective amygdalohippocampectomy. So this is the surgical scar. This is an MRI that was done after the surgery. So he had a selective amygdalohippocampectomy, and this rendered him completely seizure-free. I followed him for 16 years since this surgery, and this person continues to be seizure-free. I have been able to lower his medication. Initially, when he came to me, he was on 3 anti-epileptic medications. Now he's on a tiny dose of a single anti-epileptic medication. When I tried to lower this last medication, he started experiencing some deja vu feelings, and we mutually agreed to continue with this medication for now. And his quality of life is significantly better, and he's completely seizure-free. Let's talk about our second patient. So this is a 48-year-old woman who presented with daily episodes of staring off into space and loss of awareness. Some of these episodes were associated with loss of bladder control, which was very embarrassing, especially in social settings. She had no history of febrile seizures or head injury as when comparing to our previous patient, but she did have meningitis at 7 years of age. I don't have the details of what kind of meningitis or how she was treated at that time. She denied any history of tonic-clonic seizures in her life. She had tried carbamazepine, lamotrigine, phenobarbital, phenytoin, and levetiracetam without any significant improvement in her seizure frequency. In fact, she believed that anti-epileptic medications made her quality of life worse, not better, because the episodes, the seizures, continued at the same frequency, but now on top of it, she was also experiencing side effects. So I ordered an MRI of the brain and admitted her for video EEG monitoring and later for intracranial EEG. So initial MRI demonstrated mesial temporal sclerosis on the right side. So you see the increased signal, you see the atrophy and loss of architecture. This is not the best quality of MRI, but this is what we had available at that time. And basically the MRI was suggestive of mesial temporal lobe sclerosis. I got a plain EEG on her, and this showed sharp waves in the right temporal head region. So these are the sharp waves. These are the epileptiform discharges that you see in channels that end with the even number. So she had sharp waves, epileptiform discharges coming from the right temporal head region. We monitored her with video EEG monitoring, and she had seizures seemed to be coming from both sides. The problem was the seizure onset was not clear. So it was unclear if the seizures were coming from the right or the left side of the brain. And since the patient was quite interested to pursue epilepsy surgery, we brought her in for intracranial EEG. And this is the MRI with the intracranial electrodes inside the brain. So you can see the probes. This is the probe that goes into the amygdala, and this is the one that's going into the hippocampus. Now, the EEGs that are recorded from inside the brain do not follow the 1020 system. You don't use that kind of a montage. Basically, this is we recorded. This is an EEG from another patient where we had left hemisphere and right hemispheric probes, and you can see that these are probes from the right amygdala. These are probes from the right hippocampus. The contact 1 is the deepest contact. Contact 8 is the most superficial contact. So going back to the MRI here, this is the deepest contact right here. So this is contact 1, and the most superficial contact will be the contact 8. So with this interictal EEG with depth electrodes, we found that both the hippocampus and amygdala were quite active with spikes. This is one of the seizures, and you can see the onset of the seizure from the deepest contacts of the right amygdala and hippocampus. This is the first page of that seizure, and the seizure evolves. You can see the seizure is evolving in frequency, seizure is evolving in amplitude. Higher amplitudes are seen here. This is the evolution of the seizure, and this is the termination of the seizure. This patient was also considered. I had a long discussion with the patient. discussing the pros and cons, merits and demerits of epilepsy surgery, and she decided to go for surgery approximately a few years ago and has been seizure free. She, however, has continued taking anti-epileptic medications, although on a lower dose. So basically, what the message to take home from this tutorial is mesial temporal lobe epilepsy can be easily recognized with proper clinical history and investigations. Patients typically present with spacing out episodes, blanking out episodes. Some patients will have olfactory hallucinations as if they are smelling some burnt toast. Some people have gustatory hallucinations with metallic taste in their mouth. There are patients who can experience deja vu. Most patients do not experience tonic-clonic seizures unless they abruptly discontinue the medications. Some patients who are living by themselves may be unaware of their unawareness. So unless somebody is with them, somebody is having a meaningful interaction with them, you would not even be able to quantify the number of seizures. So patients who think that they have 1 or 2 seizures at home in a week, when we bring them in for video EEG monitoring, sometimes we find out that they've had 10 or 20 more seizures than what they have realized. So just because a person thinks that they are not having a seizure does not mean that all seizures are being properly recorded. Surgery for mesial temporal lobe epilepsy can offer a potential cure. I've seen many patients who after the surgery have completely come off the medications and have been completely seizure free. Having said that, there are still a lot of patients even after surgery who require to be on medications, and then surgery does not offer a 100% cure. It offers significant reduction in seizures in 50 to 60% of patients. So there are still patients who will continue to have ongoing seizures. It is important to consider surgical option in all patients with focal seizures that are refractory to medical therapy. So with this, I will end the tutorial here. I ask you and request you that if your center does epilepsy surgery and is involved in epilepsy surgery, kindly leave that in the comments about your center as well, so that patients or other physicians who are looking to refer patients for epilepsy surgery have proper contacts. If you're not from Canada or the US, it is even more important to identify centers that do offer epilepsy surgery. If you're from India, Pakistan, or any of the other countries of the world, kindly leave a comment about centers in your country that offer epilepsy surgery. Thank you, and I'll talk to you in the next tutorial.